deficiency, which is part of the general medicine. The aims of the lecture to study the different types of immunodeficiency, clinical manifestation, diagnosis, treatment, and then to talk about intravenous immunoglobulin infusion and subcutaneous immunoglobulin infusion. Immune deficiency status. متى نحكي أنه هذا المريض عنده immune deficiency؟ Immune deficiency is important consequences. Recurrent infection first, autoimmunity, susceptibility to malignancy. These are the three criteria by which we suspect immune deficiency disorders. These disorders can be primary or secondary. The primary with intrinsic defect, usually genetic, but may be acquired, which are rare. More than 100 types of immune deficiency are available. And most types which are genetically determined are present during childhood and adolescence. They appear early in life. Secondary, they are common. Secondary or iatrogenic to infection, to drugs, to malignancy, to aging. The old age suffer from secondary immune deficiency. So they are primary, which are rare, and secondary, which are common. We are not going to talk about 100 types. I have selected for you just a few important types that we are going to discuss them. Types of immune deficiency. Any item of the immune system could suffer from immune deficiency. Antibody deficiency, T lymphocyte deficiency, combined B and T. You know, antibodies come from B cells. So combined B and T. Complement deficiency, phagocytic cell deficiency. So all items of the immune system can suffer from immune deficiency. The general presenting problems, we said infections. What are the characteristics of these recurrent infections? Severe, caused by unusual microorganisms, of low virulent, commensal, and they occur at unusual sites in places which are not common for that infection. Sometimes we can know whether the patient is suffering from humoral immune deficiency, which is antibody or B cell deficiency, or from cellular immune deficiency, which is the cell-mediated immunity deficiency. So humoral and cellular. Those patients who suffer from antibodies immune deficiency due to B cell defect suffer from infection with extracellular bacteria لأنه شغل الانتيبوديز extracellular ما يقدر يدخل داخل الخلايا Giardia lambelia or enteroviruses. Cellular deal with intracellular microorganisms like viruses, fungi, protozoa, intracellular bacteria. So if the patient suffers from repeated viral infection, you expect that the deficiency is cellular. If a patient suffers from extracellular bacterial infection, you expect the deficiency is in antibodies or B cells. Let us take the primary antibody deficiency. During infancy and early childhood, there is a disease called X-linked agammaglobulinemia, or sometimes called hypogammaglobulinemia. It's called the Bruton's disease. The scientists who discovered this disease named Bruton's. This disease affects only males during infancy or early childhood, so females are not affected. There is an arrest of the B cells at the pre-B cell stage due to tyrosine kinase enzyme defect or deficiency, TKE, tyrosine kinase enzyme. And sometimes this is under control of gene. So we have to detect the TK gene, tyrosine kinase gene. And this will result باقي لنا 10 دقائق وعلى الأكثر ما نخلص راح نجدد دخولنا مرة ثانية. تمام؟ The patient will suffer from very low IgG level and absence of other immunoglobulin, MADE, and also absence of B cells and the plasma cells, because the cells are arrested at the pre-B cell stage. As you know, the B cells appear from the stem cell and pass into stages of pro-B cell, pre-B cell, immature B cell, and then mature. Here, the defect in the TK enzyme due to defect in the TK gene and arrested at the pre-B cell stage. This will result in very low IgG. The patient usually suffers from recurrent infections of respiratory tract leading to bronchiectasis. And the patient characterizes a major diagnostic feature, very tiny tonsils. Why very tiny tonsils? Because the B cells are arrested. They are not migrating to the secondary lymphoid tissues. Now, treatment to give intravenous immunoglobulin or subcutaneous immunoglobulin as a replacement therapy. Look to the word replacement therapy. نعوض المريض عن نقص الاي جي جي اللي عنده ونقص او انعدام وجود بقيه الاميونوغلوبولين. This picture summarizes to you B lymphocyte function and the primary antibody deficiency. Here we are talking about antibodies and B cells. This is the bone marrow. You have the stem cells. And here, from the stem cell, you get the lymphoid progenitor, and then immature B cell, then the mature B cells, as I described. So if you have a deficiency here, failure of lymphocyte precursor, this will give you severe combined immunodeficiency. I will explain this deficiency with the cellular. Now the progenitor. Here we have failure of B cell maturation. We have a disease called X-linked agammaglobulinemia, which is the bruton. Just I have discussed it. So there is arrest here before the immature B cell. Now, the immature B cell will switch to mature B cell. Now, we have failure of a production of IgG. This we talk here about common variable immunodeficiency and also another condition called specific antibody deficiency. يعني الخلايا البي سيل لا تنتج IgG. You know, once the B cells start to produce antibodies, when they become plasma cells, they start with IgM, and then there will be switching to other immunoglobulin like IgG, IgE, IgA. If there is no switching, there will be IgM production, which is called hyper IgM syndrome. For example, we have another condition, failure to switch to IgA production. So we are going to talk here about selective IgA deficiency. I will talk about, so IgG, it will result in common variable immune deficiency. IgG specific antibody deficiency. For IgM switching failure, hyper IgM. IgA, there will be selective IgA deficiency. So let us talk about selective IgA deficiency. This is very common condition. It occurs in about 1 in 600 people. This is in Europe. The IgA is absent or very low, less than 50 milligram per deciliter. The normal value is between 100 and 200 milligram per deciliter. So there will be compensatory high serum IgG. يعوضنا. The patient will have normal numbers of B cell and T cells. Such deficiency occurs accidentally. مريض جاي يفحص عندك routinely. It will produce severe allergy لأنه المريض ما يعرف الاي جي اي، ما شايف الاي جي اي. If you give IgA, the patient will suffer from anaphylaxis, from allergy. So the only treatment available is to give antibiotics to control infections. Common variable immune deficiency, اللي تاع IgG. This is heterogeneous, a group of immune deficiency. Unknown cause, defect in the B cell maturation, related to genetic susceptibility, and in the T cell regulation function of the B cells. Both sexes are affected equally. The age between 15 and 35 years of age, it appears a bit late. The CVID is called. Remember the word CVID. It is characterized by low serum, total serum immunoglobulin, less than 350 milligram per deciliter, usually between 1000 and 1500, بين 1000 وال 1500. Normal value. Low IgG level, less than 250, and failure of to make antibodies to exogenous pathogens. Low or absent IgA, IgE, but normal or low IgM. The numbers of B cell and T cells are variable. That is why it's called common variable. CVID accompanied by autoimmune diseases such as idiopathic thrombocytopenia purpura, autoimmune hemolytic anemia. Furthermore, CVID also associated with an increased risk of malignancy. What sort of malignancy? Lymphoproliferative diseases. Patients suffer from a bronchiectasis due to repeated respiratory tract infection, and this should be checked by CT scan every 5 years. So these patients, in their follow-up, every 5 years should have CT scan of the chest. Now another deficiency called functional IgG deficiency, or called a specific antibody deficiency, previously called IgG subclass deficiency. Here the deficiency in subclass of the IgG, mainly IgG2. You know, IgG is of 4 subclasses, 1, 2, 3, and 4. The patient will suffer from deficiency in IgG2, sometimes of IgG4. These conditions are due to defect in response to polysaccharide antigen. These patients cannot mount immune response against polysaccharide. However, other immunoglobulin, B cell, T cells are all normal. Only the deficiency in the subclass, mainly IgG2 or less likely IgG4. Investigation of the primary antibody deficiency. Total serum immunoglobulin concentration. لازم نقيس الانتيبوديز الاميونوجلوبولين. Measure specific antibody response against certain microbes